I have the pleasure of presenting on mental health and neurocognitive issues related to adolescents who have grown up with HIV. And you may ask, but we're talking about long-term HIV, and I think one of the things that I'd like to share is perhaps some experiences from the United States, also with regards to the long-term survivors in terms of our adolescents who are born with HIV. So I have no conflict of interest to disclose, except for the fact that I started working with HIV as a child and adolescent psychiatrist treating HIV-positive children, and over the last 2 decades, having the opportunity to see them grow up and become flourishing adults has taught me a lot about some of the neurodevelopmental as well as some of the psychiatric issues affecting their lives, but also interfering with their treatment and their outcomes in terms of HIV care. So I thought that being in Hong Kong, it would be helpful to just orient some principles with regards to mental health, and as we're thinking about HIV in particular. So from the outgoing Director General of the World Health Organization, Dr. Margaret Chan, mental well-being is a fundamental component of WHO's definition of health. Good mental health enables people to realize their potential, cope with normal stressors of life, work productively, and contribute to communities. What's really important is that mental health matters, but the world has a long way to go to achieve it. So I think about yesterday's opening plenary speakers and some of the issues that were raised, which I think were very important, because I think that issues related to stigma and discrimination continue to exist, not only with regards to HIV, but in particular to mental health. And when we think about having neurobiological or actually medical treatments that are available to treat mental illnesses, it is sobering to appreciate the fact that many of those who need the treatment never receive it. And when we think about low and middle income countries, it's estimated that 80% of those individuals with mental illness do not receive treatment. High income countries don't do very much better, so approximately about 50% of those individuals who need the care actually receive the care. So I think appreciating the role of stigma as well as the barriers to care are not only unique to HIV, but also are shared with mental illness. So the other question is really, why are we focusing on mental health? We think about the World Health Organization's Mental Health Action Plan, which is 2013 to 2030, and we think about what is the impact that mental health issues play in terms of our global burden of disease, appreciating how disease affects populations as well as their ability to contribute to society. So it accounts for 13%, and depression in particular accounts for 4.3% of the global burden, and this largest single cause of disability worldwide. And that's greater than cardiovascular disease and greater in terms of the neuropsychiatric contributions, greater than oncology, cancer, and other medical issues. Within Asia, mental health in particular contributes to 20% of the years lost to disabilities as one of the measures of how illnesses affect populations. The prevalence that we think of in terms of depression globally is 1 in 10. When we think about suicide, it is the 17th leading cause of death worldwide, but among youth, 15 to 29, it is the 2nd leading cause of death. So in addition to the lives lost, I think we're also thinking about the economic burden. And when we're thinking about 2013 to 2030, the economic cost of not addressing mental health is about $16 trillion estimated by the World Economic Forum. So shifting our gears a little bit to why are we focusing ourselves on adolescence in addition to mental health, I'm quoting the American anthropologist Margaret Mead. There is no greater insight into the future than recognizing when we save our children, we save ourselves. And I think that taking an anthropological approach to adolescence is helpful because at many times, a lot of the behaviors seem nonsensical and sometimes with regards to the decisions they make, rather impossible. So I think that being able to respect our adolescents, but also approach them with the curiosity to understand what their experiences are, allow us to best serve them. So just as an overview of my talk this morning, I will talk a bit about the developmental framework for adolescents, as well as the social determinants for mental health, as well as the neurocognitive disorders. What do we know to date after 3 decades of HIV, as well as from our information from our perinatally HIV-infected youth, as well as a review of our mental health disorders, most of that data coming from the United States. So what's important to acknowledge is that adolescence is a very active time, particularly in the central nervous system, with regards to the developing brain. There's brain maturation into early adulthood, and some of the most important abilities and domains, including the executive functioning, as well as our ability to be mindful of the decisions we make, occur really into the early 20s. The peak of the gray matter occurs early in adolescence, and there's active pruning that occurs between the prefrontal cortex as well as our midbrain and our amygdala in terms of our reward centers that allows adolescents and really young adults to be thoughtful of the decisions they're making, regardless of their hormonal and or other impulsive urges. Adolescents are close to the peak of their physical health and strength, yet their mental capacity continues to develop. I think we appreciate that mortality rates increase through adolescence, primarily because of the issues that are developmental, sensitivity to peers, impulsivity, novelty seeking, and limited self-control. And these are tasks we hope will be accomplished through adolescence. So this is a visual of some of the issues that I discussed. I think, as you can see, in terms of the neuronal and the synaptic connections increase through early adolescence, but there's a very active pruning process that occurs during adolescence, and this is really important, and potentially issues related to mental health as well as HIV can perhaps affect that process. What's most important is with regards to the prefrontal cortex and some of the executive functioning skills that I'll talk more about. The developmental of the brain also dovetails with the emergence of psychiatric and mental health disorders. So this is just a graph demonstrating the fact that with regards to disorders such as ADHD, attention deficit hyperactivity disorder, the peak occurs at around the age of 6 or 7. However, it can begin as early as 3 to 5. So I think what's really important is that as the brain is developing, so are the potential vulnerabilities as well as the neuropathological issues related to psychiatric illnesses. As you can see, anxiety disorders peak pre-pubertally, and with regards to mood disorders such as depression, they start at around puberty and continue through to the early adolescent and adulthood. So as we're thinking about how do we understand mental health issues for children, adolescents, and young adults, it's important for us to appreciate the saying that it takes a village to raise a child. However, it's really what happens in that village and what happens to that young person with regards to where they're living, who they're living with, their social and sort of environmental issues that can impact their development as well as their expression of mental illness as they emerge through adolescence. So issues related to psychosocial adversity, stigma, violence, poverty, racism, discrimination, housing insecurity, as well as their caregiver status are very important. And particularly with perinatal HIV, you can appreciate that there are many of these different issues affecting the development of a young person. So what are some of the specific challenges facing perinatal HIV-infected adolescents? In the resource-limited settings or lower middle-income countries, where really over 90% of the perinatally infected HIV adolescents live, there is great psychosocial adversity affecting their development, as well as sometimes inadequate access to antiretroviral treatment or late initiation of treatment, as well as drug resistance that can develop with that experience, as well as adherence issues and how do we best promote adolescents and young people to take their medications. And with regards to contrasting to the resource-rich settings or high-income countries, I think that it allows us an opportunity to look at what is a window into the future. So as these young people in some of the higher income countries have benefited from continuous antiretroviral treatment, although not ideal at the beginning of the epidemic, we can learn from what their experiences are with regards to their neurodevelopmental issues as well as their psychiatric histories over time. So this is just a snapshot of what the demographic looks like in the United States with regards to perinatally acquired HIV. So of about 11,000 individuals, about 66% of them are between the ages of 13 and 24, and 16% are between the ages of 25 and 34. So some of my oldest perinatally infected young people are in their early 30s who have started their families, who have definitely informed me in terms of understanding the needs of this population. With regards to what is experienced in Asia, I think it's a very different picture because when we look at the adolescent data, it combines both the perinatally infected youth as well as those that are behaviorally infected. However, as we heard from the plenary speakers yesterday, there is an alarming trend that we need to attend to. So as we think about the UN AIDS, ending the AIDS epidemic for adolescents, as well as the UNICEF cause of under the radar, there are some alarming statistics with regards to adolescents in the region. It's estimated that 600,000 young people aged 15 to 24 are living with HIV. They represent 37% of the new infections in the region, despite only being 12% of the whole population living with HIV. AIDS death rose between the ages of 10 to 19, 110% between the period of 2005 and 2014. This definitely raises the alarm with regards to the effectiveness of treatment and engagement of treatment, which we heard more about yesterday. Many of the young people are diagnosed late, but they also have the highest incidence and lowest access to care. And it is estimated that 220,000 adolescents aged 10 to 19 are within the Asian region. So these are just some visuals with regards to some of those statistics in thinking about the total population, about 600,000, but also with regards to the new infections, about 100,000. And the pink is the young women and the blue is the young men. So when we're thinking also about the children, 0 to 14, these are primarily the perinatally infected young people mostly, and we're thinking about Thailand and their successful PMCT strategies in terms of eradicating that. We definitely challenge the region with regards to achieving the same success because this will continue to contribute, unfortunately, with perinatal transmission. And this is just a slide looking at the AIDS-related death, 10 to 19, which we had heard a little bit about in terms of increasing over the period of 2005 to 2014. So I think we need to definitely think about what are the strategies. And some of these strategies will relate to some of the key target populations, as well as some of the perinatally infected youth challenges. So with that, thinking about the neurodevelopmental issues with perinatal HIV, what have we learned from the United States and from some of the high-income countries? The initial impression was that infants and children had significant neurodevelopmental impairments associated with early severe HIV disease, and most specifically HIV encephalopathy. What we did learn was that HIV antiretroviral treatment decreased the incidence of HIV encephalopathy since the mid-1990s. The current impression is that youth with AIDS-defining illnesses or HIV encephalopathy are the individuals who have the worst outcomes with regards to neurodevelopmental issues as well as psychiatric comorbidity and severity. Overall, there are a few differences between the perinatally HIV-infected young people as well as their HIV-exposed brothers and sisters and adolescents with regards to cognitive function, language, and academic functioning. However, they are different from the HIV-negative cohort of their community. So they both perform lower than that population. A meta-analysis that was done by Phillips et al. Reviewed the neurodevelopmental outcomes, demonstrated that perinatal HIV young people compared to HIV-exposed adolescents had impairments in these three major domains, which relate to the prefrontal cortex, which was that arrow in the graph earlier on with regards that it develops into the early 20s, working memory, processing speed, as well as executive functioning. Some of the additional factors that we've learned from the United States that contribute to mental health include some of those I think the social demographics and parental factors such as older age, racial minority, male gender, low income, low caregiver, education, or IQ are also factors in terms of neurocognitive development for these young people. So moving on to the mental health issues. And from here, I'm going to draw from some of the experiences in Asia as well as some of the experiences in the United States. So the prevalence of mental health issues with regards to perinatally infected youth internationally, approximately about 28 to 48%, and this is from information from Zambia as well as from Thailand. And in the United States, it's estimated to be about 61%. And some of these other social determinants, such as ethnic minority status, poverty, psychosocial adversity that I'd spoken about, are some of the major contributors to mental health issues. So within Asia, the literature is limited, at least in terms of the literature I was able to find, and thank you, Dr. Son, for sharing her sources with me. But the methodology and the study design, some of the challenges are really having randomized controlled trials with regards to interventions. And there were only studies that I could find from a review article showed that for China and Thailand, really focused on HIV-positive adults. And with regards to some of the HIV mental health studies that have been done, a nice review article by Niu et al. Showed that the median prevalence of depressive symptoms within that country were about 60% lifetime prevalence of major depressive disorder, but 23% in anxiety disorder, 16%. There's also a concerning statistic around suicidal ideation and suicide attempts, higher than the baseline population. However, many of these studies are not necessarily utilizing structured and semi-structured psychiatric diagnostic assessments, so I think we have to take all of this data with a grain of salt. With regards to Thailand, they've done much of the research in terms of the perinatal HIV population, looking specifically at counseling sessions in a comprehensive youth program, as well as youth counseling, need survey, and individual counseling, finding that there are some positive effects with regards to the utilization of specific mental health interventions within an integrated health setting. Transition to care continues to be a challenge, and some of the lessons learned there mirror some of the American experiences. So with that, this is from a colleague of mine, Azur Kang, who shared that much like I spoke about the village raising a child, it's really all of the social determinants and the interactive factors that contribute to a young person developing, but also how well they can manifest either any developmental strengths, but also any risks to their HIV care. So in general, the prevalence for the mental health diagnosis within the United States is about 2/3 of the perinatal HIV-infected youth have a mental health disorder. And as you can see, the higher prevalence rates of ADHD, anxiety disorder, and depression are the three most common psychiatric domains affected. In terms of looking at the perinatally infected youth compared to their HIV-negative siblings, but are also HIV exposed, the data is actually very similar. So they both have very high rates of psychiatric comorbidity, 61% to 69% for perinatal HIV infected, and for the HIV exposed, 49 to 70%. I think one of the things that we learn is that all of the social determinants and the contextual factors that relate to the development of mental illness, such as intergenerational substance abuse, intergenerational mental illness, as well as poverty and socioeconomic status, continue to contribute to these mental health issues. What's really important to notice is that for the perinatally infected youth, the things that predict more of a mental health issue with regards to psychiatric diagnosis are the presence of an AIDS-defining illness or often poor adherence to their HIV care and poor health outcomes. The most common diagnoses include the anxiety, ADHD, and the mood disorders, depression being most common. And the perinatal HIV-infected adolescents were more likely to receive mental health treatment. That's often with regards to them actually being in care more often and maybe having increased access to treatment. So just in general, in looking at our perinatally infected young people, perinatal HIV-infected youth receive more psychiatric medications as well as more psychiatric services, probably related to their increased access to care. Psychiatric medications are used fairly commonly, 23 to 45%, and we can estimate that they're fairly well tolerated with regards to this population of young people on antiretroviral treatment. What's important to note is that there are high comorbidity rates with regards to psychiatric illnesses. Kapanovich looked at psychiatric diagnoses. 55% of them met criteria for one disorder, 27% met criteria for two disorders, 17% met criteria for three psychiatric disorders. And when we look at the adherence issues, and many of the studies have looked at adherence factors, 35% of perinatally infected youth in the United States could be non-adherent to their HIV medications. Mental health, not surprisingly, comes to the top in terms of one of the risk factors contributing to that poor adherence. So in summary, and also some of the next steps, neurocognitive issues will be influenced by access to the effective and timely pediatric antiretroviral treatment. So I think as we close in on the 90-90-90 goals, hopefully we'll have less of these issues presenting over time. The severity of HIV disease predicts the degree of both the neurocognitive as well as the mental health and psychiatric comorbidity. So it's really important for us to treat the medical issues that will then protect against the neurodevelopmental and psychiatric issues. Understanding the scope of the mental health challenges with perinatal HIV, but also with regards to mental health in Asia, will be very helpful in understanding what are some of the barriers to effective HIV care within the region, particularly with a note to culturally sensitive and strengths within the region so that you can define interventions that are most appropriate. Also exploring and research mental health treatment strategies, and this is a great opportunity to enter the field with regards to understanding this population and how they affect HIV care. And also appreciating the unique risks and challenges of adolescents that they transition to adult settings, because adolescents are not adults, but they are moving into your adult treatment settings, and better understanding their needs and also their challenges will help with their HIV treatment success. And with that, I'd like to thank actually Claude Mellons, who's a research HIV psychologist who I've had the pleasure of working with, Annette Son for inviting me, as well as also the children that I've had an opportunity to work with. So all the HIV positive young people, for the privilege of their experiences, the wisdom of their years. Knowledge comes from learning, wisdom comes from living. Thank you.